In earlier videos, we talked about hypothyroidism in parts. We looked at the different types of thyroiditis like Hashimoto's, subacute and postpartum thyroiditis. We also discussed the symptoms of hypothyroidism while learning about the functions of thyroid hormones. In this video, we will put all that information together and get a clear, complete picture of hypothyroidism. Hypothyroidism is a clinical syndrome resulting from a deficiency of thyroid hormones, resulting in a generalized slowing down of the metabolic process. In case of infants and children, the hypothyroidism results in marked slowing of growth and development with serious permanent consequences, including mental retardation when it occurs in infancy, that is the cretinism. In case of adults, the hypothyroidism causes generalized slowing of metabolism with slow heart rate, decreased oxygen consumption, decreased appetite, etc. And now the cause, as we discussed earlier, that hypothyroidism may be due to the failure or resection of the thyroid gland itself, or it can be due to the deficiency of pituitary TSH. If the hypothyroidism is due to the failure or resection of the thyroid gland itself, this condition is what we called as the primary hypothyroidism. And if the hypothyroidism is due to the deficiency of the pituitary TSH, then we termed as secondary hypothyroidism. So the primary hypothyroidism is due to the intrinsic disorder of the thyroid gland. The detailed discussion on individual cause has already been covered in separate videos. So if you have not watched it yet, go check those out first. It will give you a much better grasp and make today's discussion easier to follow. The first and most important cause of primary hypothyroidism is the autoimmune thyroiditis, that is Hashimoto's thyroiditis, or also known as the lymphocytic thyroiditis. It is the most common cause of hypothyroidism. A hypothyroid phase also occur in subacute, that is post-viral thyroiditis, and in postpartum thyroiditis. Following initial hyperthyroid phase, this phase is usually transient and usually self-limited. The hypothyroidism can also develop due to the subtotal thyroidectomy for the grave disease. Nodular goiter is also a cause of hypothyroidism. The nodular goiter is the enlargement of the thyroid gland. It is due to the deficiency of iodine or presence of food goitrogen in iodine deficient area. For example, turnips, cassavas, or infiltrating disease like sarcoidosis and cancers. The nodular goiter develops when the thyroid unable to produce enough thyroid hormones. It may be due to the deficiency of iodine. The reduced hormone level triggered increased secretion of thyroid stimulating hormone. The elevated TSH continuously stimulates the thyroid gland, leading to its enlargement and overgrowth, which eventually appear as a nodular goiter. The goitrogen medication include iodine, the antithyroid medications such as propylthiouracil and methimazole also inhibit the synthesis of thyroid hormones. As the result, the thyroid hormones levels fall, which stimulate the pituitary gland to release more TSH. This persistence high TSH level keeps stimulating the thyroid gland, leading to its enlargement. And other drug includes sulfonamides. Sulfonamides can interfere with the synthesis of thyroid hormones, especially when taken for a long period. Amiodarone, because of its high iodine content, cause significant hypothyroidism. The T4 level is low or low normal, and TSH is elevated, usually over 20 ml unit per liter in case of amiodarone. Lithium also get concentrated in the thyroid gland and directly inhibit the release of T3 and T4. It has been observed that the 50% of the patient taking long-term lithium medicine have an ultrasound detected goiter. And then the excessive iodine intake. The hypothyroidism may also develop in patients with high iodine intake, especially if they have underlying lymphocytic thyroiditis. A complete pathophysiology we already discussed, where we discuss how increased intake of iodine can cause thyroiditis. Please go and watch. Then we have the chemotherapeutic agents. Chemotherapeutic agents like tyrosine kinase inhibitor, interferon alpha 1, interleukin 2, thalidomide can also cause a silent thyroiditis that can lead to a hypothyroidism. Secondary hypothyroidism is due to the hypopituitarism. It may be due to the pituitary adenoma, pituitary infiltration, or any trauma or destruction to the pituitary gland, leading to the decreased secretion of TSH and ultimately decrease the synthesis and release of thyroid hormones. Normally, thyroid hormones increase the metabolic activity by stimulating the ATP production and heat generation, and thereby maintaining the body's basal metabolic rate, that is BMR. In hypothyroidism, due to deficiency of thyroid hormones, both ATP production and heat generation is reduced. This leads to decreased BMR and overall heat production. To conserve the little heat that is produced, the body responds with peripheral vasoconstriction. However, this vasoconstriction reduces the blood supply to the skin and muscles, which explains several clinical features of hypothyroidism, that is, pale, cold, dry skin due to reduced skin blood flow, fatigue and muscle cramps due to poor perfusion, and reduced energy availability in muscles. Generalized sense of coldness and discomfort because of impaired thermoregulation. In hypothyroidism, the decreased BMR. What is BMR? In easy words, BMR is body's energy use at rest. So high BMR means more energy use and low BMR less energy use at rest. As in hypothyroidism, there is decreased BMR, so less energy used, and ultimately reduces body's demand for oxygen and carbon dioxide exchange. As a result, both rate and depth of respiration decline. This hypoventilation predisposes patients to carbon dioxide retention, carbon dioxide buildup, and even sleep apnea. These respiratory effects further contribute to fatigue and drowsiness commonly seen in hypothyroid patients. In hypothyroidism, because of decreased metabolic rate, which lowers the tissue requirement for oxygen, because of decreased oxygen demand, the kidneys sense less need to stimulate the red blood cell production. As a result, the production of erythropoietin, the hormone that drives bone marrow to form new red blood cells, diminishes. This reduced erythropoietin output leads to decreased erythropoiesis in bone marrow and ultimately results in normocytic, normochromic anemia commonly seen in hypothyroid patients. Thyroid hormones required for conversion of beta-carotene to vitamin A in the liver. In hypothyroidism, the beta-carotene accumulates in the skin, particularly in subcutaneous fat, produces yellow discoloration of the skin. Since it is due to the carotene and not due to bilirubin, so the sclera remains white, which is the important differentiating point from jaundice. In hypothyroidism, because of decreased T3 and T4 hormone, the hypothalamus senses the decreased level of thyroid hormone in the periphery and results in increased production of TRH. The TRH stimulates the anterior pituitary and increases the production of TSH, and also increases the production of prolactin. This increased prolactin level inhibits the GnRH release from the hypothalamus, resulting in decreased LH and FSH levels in the blood. Decreased LH and FSH levels in females result in menstrual irregularities, anovulation, infertility. In males, it causes decreased libido, erectile dysfunction, decreased sperm count, and may lead to gynecomastia. On heart, normally the thyroid hormone increases the beta-adrenergic receptor expression on the heart, resulting in tachycardia and increased BP. In case of hypothyroidism, the beta-adrenergic receptor expression on the heart is decreased, which results in bradycardia, decreased cardiac output, decreased stroke volume, and ultimately decreased BP. The pulse pressure is also reduced in case of hypothyroidism. In hypothyroidism, the blood sugar level may appear better controlled. Normally, the thyroid hormone increases glucose absorption from the intestine and stimulates the gluconeogenesis in the liver. Both cause raised blood glucose level. However, in hypothyroidism, there is reduced blood glucose absorption from the gut and decreased gluconeogenesis, leading to lower blood glucose level. And also, because of decreased thyroid hormone, the insulin metabolism becomes slower, so insulin action is prolonged. So diabetes controlled in hypothyroidism appears better because of decreased blood glucose level and increased insulin action. But because of prolonged insulin action, there is increased risk of hypoglycemia. And in case of lipids, normally the thyroid hormone stimulates the process of lipolysis by breakdown of stored fats into free fatty acids. Also, thyroid hormone increases the cholesterol clearance by upregulating the LDL receptor in the liver, which helps to remove LDL cholesterol from blood. So, in hypothyroidism, there is increased risk of hypercholesterolemia because of decreased LDL receptor on the liver, and also because of decreased breakdown of stored fat resulting in weight gain. In prolonged primary hypothyroidism, as there is increased TSH level, these increased TSH levels stimulate fibroblasts in various tissues. These fibroblasts increase the synthesis and deposition of hydrophilic glycosaminoglycans such as hyaluronic acid and chondroitin sulfate within the interstitial matrix. As hydrophilic, they trap fluid in the interstitial matrix, leading to non-pitting edema, which we will call as myxedema. As seen in hypothyroidism, this process explains the clinical manifestations like puffiness of face, periorbital edema, macroglossia, which can cause obstructive sleep apnea, hoarseness of voice due to laryngeal tissue infiltration, carpal tunnel syndrome because of median nerve compression. The commonest cause of non-pitting edema in case of females is hypothyroidism, and these are the clinical features of hypothyroidism.